Good morning, everyone. Thank you, Brad. Firstly, I'd just like to say how much of a privilege it is to have the opportunity to present this Tuesday lecture. And before we begin and delve into the lecture topic, I just need to say that I have no conflict of interest to any of the data that I present here today. And as Rod said, the topic of today's presentation is Achilles tendinopathy, and in particular how, by challenging some assumptions that we may have about the treatment of Achilles tendinopathy, we can potentially improve the rehab outcomes for athletes, because as many of us know from a patient perspective and also from a healthcare practitioner perspective, tendinopathy and Achilles tendinopathy can be a frustrating disorder for all involved. And I chose, I suppose, the theme of assumptions and challenging assumptions from, number one, my own personal experience, but number two, because I know that challenging assumptions are part of our everyday life, be that in a social context, personal context, or workplace context as well. And for me, as an Irishman, I'm probably not immune to the whole idea of assumptions and assumptions about being an Irishman. So when I came here, and many of the conversations I had, and many of the assumptions that people had about me as an Irishman were, why don't you have red hair? Don't all Irish people have red hair? Or why aren't you eating potatoes for your breakfast? Because that's all Irish people do. And how come you have freckles? Because all it does in Ireland is rain. And although there might be a sentiment of truth in some of these assumptions, many of these assumptions are actually not true and actually wrong. And although these may be humorous assumptions about being Irish, there are many, many examples of how, by challenging assumptions throughout history, we've actually led to the improvement in knowledge for us as mankind. And there's many examples, such as walking on the moon, which was assumed was never possible. Or for many hundreds of years, we assumed that the world was flat. And again, that seemed like a logical assumption for many years. But only by challenging this assumption, this led to attainment to new knowledge and new discoveries. And again, there's many more examples. If you asked a Philadelphia Eagles fan a couple of nights ago, before winning their first Super Bowl, they would have assumed that they would have never won a Super Bowl either. And again, by challenging assumptions, we can potentially improve knowledge. And I think that holds true as healthcare practitioners as well. And I think the challenge and onus on us as healthcare practitioners is to continually challenge assumptions that we have about pathology, or particularly about our treatments, in order to improve the clinical outcomes for our patients. And again, I think over the last number of years we've been relatively successful with this, and it's probably an ongoing battle. So for many years we assumed that if someone had low back pain or had a back injury, the best thing they could do was bed rest. And that was the accepted assumption as a treatment approach for low back pain. But we now know that the best thing you can do for low back pain is actually have relative rest and encourage the patient to stay active and stay moving. And again, through challenging that assumption, that led to improved patient outcomes. And again, there's many more examples, such as here in Aspetar, Rod's work and Nichols' work in terms of hamstring injury. So again, it was assumed if I sustained a hamstring injury, getting lost during that 5k run that turned into an 11k run, that the best thing I could do is rest it for a couple of weeks, do a bit of stretching, and I would return to play. But through some of the work that we're doing here in Aspetar in terms of hamstring injury, challenging that assumption and start rehab early and start aggressively strengthening the hamstring, that leads to improved patient outcomes. And I think that it's a similar situation what we're talking about today in Achilles tendinopathy. And although we've made many, many strides over the last number of years in Achilles tendinopathy, I think there's definitely some assumptions that we need to challenge in order to improve our outcomes even further. So for the purpose of today, and to avoid any conflict, I'm going to use the term Achilles tendinopathy to refer to pain in the Achilles tendon. Now I know there's much debate over there over the pathophysiology of Achilles tendinopathy, be that tendinitis or tendinosis, and that's based on the underlying pathophysiology of the disorder, but I'm not going to delve into that because that's a lecture in itself. So for today, I'm just going to refer to Achilles tendinopathy as pain in the Achilles tendon region. And that region can be mid-portional of the Achilles tendon, it can be insertional as well. And what we do know about Achilles tendinopathy, and probably feeds into the assumptions thing, is that it's got a high prevalence. So not only is it a relative prevalence in something like football, which many of us here in Aspetar are familiar with, but if we look at track and field or athletic populations in terms of running or distance running, we know the prevalence of Achilles tendinopathy be high as 50%. And so every second person that we see in elite distance runners will get Achilles tendinopathy at some stage over their career. And that's similar to something like low back pain. So it's quite a common injury in sports medicine. And second to that, and I think this definitely highlights the point of assumptions, is the persistent nature of Achilles tendinopathy. And because, in contrast to something like an ACL injury or a hamstring injury or acute ankle sprain, where we can see that mechanism of injury and we can see the trauma, often Achilles tendinopathy is insidious, gradual onset. And often a player has this Achilles tendon pain for a number of weeks or a number of months. And actually, when I was reading the literature in preparation for today, what I actually saw is that the mean symptom duration of the participants in all the studies averaged 16 months. So they had this Achilles tendon pain for 16 months, which again highlights the persistent nature of Achilles tendinopathy. But that's not all bad news, because, as I said, we've had relative success with treating Achilles tendinopathy over the last number of years. And it seems that exercise, and what I mean by exercise, or loading interventions, really help in Achilles tendinopathy. So when I mean exercise, I mean strengthening of the calf or Achilles musculotendinous unit. And there's many types of programs out there in terms of duration or intensity or contraction type. But I'm sure if I did a poll here of the ones that you're familiar with as clinicians, I'm sure you would all come up with the idea of Alfredson's eccentric only heel drop program. So as many of you are aware, the background to the Alfredson's heel drop program is back in the 1990s, Håkan Alfredsson was working as a surgical intern in Scandinavia, and he was experiencing Achilles tendon pain himself. And he implored with the surgeon at the hospital to operate on his Achilles tendon to fix his Achilles tendon. However, the surgeon declined to operate because he felt that the Achilles tendon pain wasn't bad enough. So Håkan Alfredsson took matters into his own hand and started to go home and lower himself very, very slowly off the edge of a step in an attempt to rupture his own Achilles tendon so he could be a candidate for surgery. So a number of weeks of this passed, and he started to progressively load his Achilles tendon in an attempt to rupture for the surgery. And what I actually found was that after a couple of these weeks and over a period, his Achilles tendon pain started to actually improve and eventually resolved. And hence was born the Alfredson's eccentric heel drop program. And this has been the gold standard in terms of conservative treatment for Achilles tendinopathy ever since. And I'm sure many of you have had experience with this as patients or prescribing it to your patients as well. And if we look at the greater scheme of things, and if we include Alfredson's heel drop program and other exercise programs in Achilles tendinopathy, and look and see how effective they are, it seems that they're generally effective at reducing pain and disability in people with Achilles tendinopathy. So this slide is just something that I created from the literature. So I went to the literature and I gathered all the studies that looked at the effect of exercise or loading on pain. So along the bottom of what you have is all the individual studies, and along the side what you have is their pain score out of 100. So 100 being maximum pain and 0 being no pain at all. And what you have are two lines. So that red line is your pain score pre-intervention, and that green line is your pain score post-intervention. So what we can actually see is across all of the studies is that there's a consistent trend or consistent message to show exercise or loading interventions in Achilles tendinopathy reduce pain. And that's somewhere around maybe a 7 or an 8 on a VAS down to maybe a 3 or 4, give or take. So they reduce pain over a 12-week period regardless of the intervention. That's primarily an Alfredson's eccentric heel drop program. And then if we look at the effect in terms of disability, so I'm using the term disability, I'm referring to the effect on a Visa A score. So many might be aware a Visa A score or a Visa P score are common subjective measures in tendinopathy. So they're self-administered outcome measure where the participants rate the effect of pain on their functional ability. And it's rated from 0 to 100. And what we'd expect is we'd expect pain-free people or controls to have a score close to 100 or at 100. And again, the lower you are, the more disabling your symptoms are. So what we have again is similar, that literature review of all the studies along the bottom, and these are all 12-week interventions. And along the side is what you have is your Visa A score pre and post. So your red line is my Visa score pre-intervention, and my green line is my Visa score post-intervention. And as we can see, again, similar to the last slide in terms of pain, exercise and loading programs are effective in reducing my Visa A score or reducing my disability levels. So I suppose what point are you trying to make? Is that a case of, look, just give everyone an Alfredson's eccentric heel drop program and let them do it for 12 weeks and their pain and disability improved? Alas, great, fantastic. But unfortunately it's not as simple as that, and here ties in the idea of challenging some of the assumptions that we may have, is that when it comes to exercise in Achilles tendinopathy, it's far from a panacea when we really drill down to look at the effects of our interventions. So what we actually know is that when we follow up our patients, up to 60% of patients actually have persistence of symptoms following the intervention period. Up to 40% of our patients actually go on to develop contralateral Achilles tendinopathy. And over 50% of patients, when asked of subjective satisfaction, rated their satisfaction as moderate to poor. And I think one of the most striking statistics for me when I was looking at this was that when I collated it and looked, that recurrence rate at 27%, which is extremely high. And if we look at something like hamstring injury, which is a massive problem for recurrence rates, it's similar. And I think the reason I have a star beside this figure is I actually think we're underselling the recurrence rate of Achilles tendinopathy. So that figure of 27% was based on a study by Knudsen from the Champions League data over a 10-year period. And although we all know that we see Achilles tendinopathy in football, if we were to transpose and look at that in something like track and field or athletics or distance running or military populations, I would actually think that that recurrence rate is even higher. So what all this tells me is that yes, we've had success with our interventions in terms of loading conservatively with Achilles tendinopathy. But I think that these statistics show me is that we assume that our interventions work, and particularly we need to challenge some assumptions we have about exercise. And in particular, I think we need to challenge the assumptions related to the mechanism of action of our interventions. So how our interventions actually work. And this model you might be familiar with. This was presented a couple of months ago prior to Christmas during Philip Glasgow's lecture. And again, it's just a paradigm looking at the mechanistic effect of loading. So from prescriptional load through mechanical load all the way down to optimizing form and function. And I would argue that we know quite a bit now about mechanical load in terms of Achilles tendinopathy strengthening programs, in terms of contraction type, in terms of intensity, in terms of duration. I think we also know sufficient amounts about the neural and cellular events as well, through the work of mechanotherapy and cell-to-cell communication. What I would argue we know very, very, very little about is the mechanism of action of our interventions. So what actually changes in our interventions for Achilles tendinopathy? Because the vast majority of interventions so far have looked at unidimensional measures such as pain or disability or potentially structural imaging. We know very little about what actually changes. And if we know what actually changes from an intervention, we can potentially individualize our treatment outcomes and our treatment programs to improve some of those statistics that we talked about earlier. So I think that's going to be the basis today of challenging some assumptions that we have in relation to the mechanism of action, and in particular challenging some assumptions in these three areas. So assumptions relating to structure, relating to pain, and relating to function. And hopefully by the end of the lecture you will see by challenging some of these assumptions we can potentially optimize the outcomes for our patients. So in particular, the three assumptions we're going to discuss today are one relating to structure, and the assumption that improved clinical outcomes are due to changes in tendon structure. The second assumption we're going to discuss is the assumption that improved clinical outcomes are due to restoration or resolution of tendon function. And the last assumption then we're going to discuss hopefully today, if you're all still awake, is that assumption relating to pain, and the assumption that pain in the Achilles tendon region is just an issue in the tissue. So first assumption relating to structure. So I think over the last number of years, technology has led to exponential growth of imaging in rehabilitation of Achilles tendinopathy. So many of us are aware of modalities like ultrasound and MRI, and in particular, musculoskeletal ultrasound is now used in a wide variety of settings in community and sports settings because of its portability, its reliability, and its ease of use. And again, ultrasound is very, very, very good at visualizing tendon structure, so giving us a picture of that pathological tendon or that abnormal tendon if the athlete arrives into us. And some of the features that we actually see in someone with a pathological tendon are here in this bottom picture on the right. So tendon thickening, which is just a widening of the tendon like you see, so that bowing of the tendon. Hypoechoic areas, which is kind of like a black hole effect, or potholes as some people like to say, in the tendon itself, which represents that loss of fibrillar pattern. And that firework pattern, and that colored pattern that you see, is neovascularization, so vascular growth inside the tendon, which we know is not normal in a tendon itself. And all these are features that we see using ultrasound or imaging. And the assumption is that following visualization of this on ultrasound, we assume that following an exercise intervention, improved clinical outcomes in terms of pain and disability must mean that I've addressed or I've healed this abnormal tendon or this pathological tendon. So their pain improved, so it seems likely that their structure improved, and whatever was there has now resolved. But again, when we delve down into it and challenge this assumption, this is not necessarily the case. So to investigate this topic exactly, a really good systematic review by Ben Drew's group 2 years ago in the British Journal of Sports Medicine looked at this. So what they wanted to see was that do structural changes explain the response to therapeutic exercise in either Achilles or patellar tendinopathy? So does structural change coincide with improvements in clinical outcomes? And importantly, what they actually concluded was, and this has massive clinical implications for us, is that there's strong evidence exists to refute observable structural change as an explanation for the response to eccentric exercise. And I think this is really important because sometimes as clinicians, we communicate this to our patients. We base many of our interventions and designing our interventions on addressing these abnormal tendons or fixing this pathological tendon. And we communicate this to the patient as well. And we use imaging as a primary outcome measure to check to see before return to play that their tendon structure now looks okay. Whereas this is telling us that that's not necessarily the case. And particularly we need to shift that assumption and maybe focus on clinical outcomes or functional outcomes. And again, this is not isolated to Achilles tendinopathy. And here only a couple of weeks ago, we heard a wonderful lecture by Hans Toll in terms of imaging and return to play and hamstring injury. And he outlined the huge percentage of athletes that have abnormal imaging at return to play that are asymptomatic following a hamstring injury. So it's not immune, and we see this in many other areas of musculoskeletal care in terms of back pain and the poor correlation between structure and pain. So challenging that assumption that we have about improvements in clinical outcomes leading to improvements in structure need to be challenged. But again, and there's always a but to some of these things, it's not a case of us having to throw the baby out with the bathwater. I think it's important to understand is that structure is not irrelevant, and I'm totally not saying that at all. It's particularly we need to shift our mind into looking at structure in a different way perhaps. And just to highlight that, as part of my PhD, we performed a systematic review and a meta-analysis which wanted to see, well, in two groups of people with athletes with a normal tendon at baseline and athletes with an abnormal tendon at baseline, both asymptomatic, both pain-free. Did the people with an abnormal tendon at baseline demonstrate a higher risk of developing symptoms? Now, we all know the issue with risk factors and prediction of injury through rolled bars work, but what our meta-analysis actually showed was that if you have an abnormal tendon at baseline, you're at a higher risk of developing symptoms. Now, it doesn't necessarily mean you're going to develop symptoms, but what it consistently showed was that those with an abnormal tendon had a shift to the right, which that shift away from to the right is an increased risk of symptoms. So if you had an abnormal tendon at baseline, you had a higher risk of developing symptoms. So that just goes to show, well, you're after dissing structure, but structure is not totally irrelevant when it comes to tendinopathy. And I think particularly in terms of structure, we need to shift our attention away from the morphological aspects of structure like we talked about, and particularly look at structure from a mechanical point of view, and maybe look at the mechanical properties of the tendon. So how the tendon actually behaves during a load, during running, during jumping, during athletic activity. So what I like to say to people is your Achilles tendon acts like a spring to a certain extent, or a coil. So it needs to be able to absorb. And that coil was bouncing up and down nicely this morning, but apparently not now. So your Achilles tendon acts like a coil or a spring. So it's able to absorb vast amounts of energy, like a coil, and then release that energy again. And that's the mechanical property of the tendon. And that's stiffness of the tendon. So during athletic activities, we like our musculotendinous unit to be stiff, to absorb that energy, and then release it. And on the other side of that, what we don't want our Achilles tendon to be is have a lot of strain. So think of it like a string. If I pull the string and there's a lot of strain, it's very easy to pull that string, which means it's not able to store and release that energy I need, which is really important during athletic activity. And what we can actually see now is that in people with Achilles tendinopathy, this is just something we're writing at the moment, in people with Achilles tendinopathy, they demonstrate decreased stiffness and increased strain in their Achilles tendon compared to controls. And this is really important because you can see here is that stiffness shift to the right, which means they have a decreased stiffness, and strain, or to the left, shift to the left, they've decreased strain. So again, thinking of this in that coil analogy and athletic performance, if my Achilles tendon athletes have decreased stiffness and increased strain, it affects their ability to absorb and release that elastic energy that they need during athletic performance, which might be really, really important. So you can, two things there, you're telling me that they've got structural change in their tendon which doesn't appear to be responsive in terms of pathology, and you're also telling me that they've got alterations in their mechanical properties. So can we actually change the mechanical properties of the tendon? And although the work is early on this, and this is very much an emerging area, it seems to be quite positive results. So a recent review by Sebastian Boehm's group looked at this. So in asymptomatic populations, what they wanted to see was that does a loading or exercise intervention change the mechanical properties? So can I alter that stiffness and that strain and that elastic coil effect we talked about? And what it actually seems is that exercise or loading interventions can definitely improve your stiffness and decrease your strain, which is really important for athletic activities. But I think this is a massive take-home of what they concluded and what lots of data is starting to show us now. That in order to change these mechanical properties and improve these mechanical properties, the contraction type doesn't matter. It doesn't matter what type. So it doesn't matter whether you do concentric or eccentric or isometric. And there seems to be an argument over the last decade of what side were you on. So it became nearly a civil war. Are you on the eccentric only side or are you on the mixed side? And again, what this tells us is that in order to improve the mechanical properties of the tendon, contraction type is irrelevant. But what's the most important thing is the magnitude. So how heavy and for how long I actually load that tendon. So the contraction type doesn't matter, the magnitude has to be high. And we're looking at somewhere over 70% of our repetition max, our maximal voluntary contraction, in order to change those mechanical properties. So that's the first assumption dealt with, that assumption that improved clinical outcomes are due to changes in morphological structure, which we know aren't necessarily the case. So the second assumption that we're going to discuss today is the assumption relating to structure. So I'm going to use the term structure to broadly and generally talk about the ability of the Achilles musculotendinous unit to absorb and release energy or force during athletic activities. So this could be power or strength or explosiveness during an athletic activity that the athlete needs. I think we're all comfortable with the idea, and there's enough data now to back it up to show that people with Achilles tendinopathy are weaker, so they display deficits in their tendon function or deficits in their strength, and I think that's a commonly and true assumption to make. But what I think the question we need to ask ourselves is that how certain are we that our interventions have addressed these functional deficits, and how certain are we that the athlete now has the functional demands and capabilities to go back to sport and back to performance. And just to highlight this is that I just want to show you 3 clips of athletic performance. So the first one on the left you might know as Forrest Gump, that Forrest liked to run fast. And the bottom one is a guy called Dmitry Platsnitsky, who's a Belarusian triple jumper. So if I have any people from Belarus here, I apologize in advance for absolutely butchering his name. But what these videos are used for is just to show you the huge amount of loads and tendon function that's needed in order to do what they want to do, in order for them to perform their athletic activities. So you can see here the huge amount of load, the huge amount of strength, the huge amount of function, power and reactivity that's needed in that musculotendinous unit in order to achieve that. I think we need to ask ourselves, well, are we sure that our interventions are getting the athlete back to this level? And I think that's the assumption that we make. We make the assumption that improvements in clinical outcomes in terms of pain and disability must mean that I've addressed whatever deficits are there. So their pain improved, their disability improved, so therefore their strength improved. That's my logical assumption. But that's not necessarily the case, again, if we delve down into the data to look at it. So a superficial look at the data would suggest that, yeah, look, an Alfredson's heel drop program like we see here on the far side of the screen actually leads to an improvement in maximal strength. So this graph just shows this is a 12-week intervention, so 0 weeks to 12 weeks, and this is my peak torque, so my slow peak torque assessed in an isokinetic dynamometer, so how much force I can slowly produce on my plantar flexors. And what it looks like is that, yes, my maximal strength improves as the week goes on with a 12-week intervention. However, when we look at the huge amount of data that's out there and the vast amount of studies that have looked at the effects of loading programs like Alfredson's on Achilles tendon, only 30 or just over 30% of these interventions actually report pre and post changes in tendon function. And why is that important? Because, and again, the majority of these, 32% have looked only at maximal strength measures on isokinetic dynamometer. And we know that, yes, maximal strength is really, really important, but maximal strength is only one aspect of a person's force velocity profile that they need during athletic activities like we saw during the treble jump or the distance run or a high jump. Maximal strength is only one aspect of strength. I think it's important that we understand, as a clinician point of view working in sports medicine, a force velocity curve of athletic performance. So as many of you are aware of, that force velocity curve is the inverse relationship between force and velocity. So on the far side is we have that maximal strength, which is high force but done slowly. And on the far side is what we have with high velocity movements but low force, so very explosive type movements. And I would argue is that many of the athletes that we would see in clinic, be it footballers or runners or triple jumpers or volleyballers, they not only need vast amount of maximal strength, but they also need vast amount of explosive strength and reactive strength too. And to date, very little studies have actually reported pre and post function or changes in muscle strength. And in the ones that have done it, they've only reported on maximum strength. And as a result, we know very, very little about this component of a person's strength profile. And if we want to get them back to performance, get them back to functioning at the level they would have done before, how certain are we that they've regained this through a 12-week heavy slow intervention program? And again, there's lots of data to back this up. And as part of my PhD, we performed a review that wanted to look to see, well, we know that people with Achilles tendinopathy display reductions in strength, but what is the scope of those strength deficits? Is that all across that curve we just looked at, or are they just deficits of maximal strength? And what we actually found was that, yes, people with Achilles tendinopathy displayed deficits in maximal strength, but they also displayed deficits in that explosive strength or that reactive strength that we just talked about in terms of hopping or jumping or rate of force development, which is how quickly and how explosively I can produce that force during athletic movement. So what we have here is that shift, again, of that meta-analysis of plot, is that a decreased hop is the shift to the right, and a decreased rate of force development is a shift to the right. And we can see that consistent message of a decrease in hopping ability and a decrease in rate of force development or explosiveness in people with Achilles tendinopathy. And again, a really nice study by Karen Silbernagel's group seems to back this up. So what they did is that they performed a standard usual intervention period for over 12 weeks, which actually was 6 months, which is really rare in Achilles tendinopathy studies. But the important thing is they followed the patients up at 6 months and 1 year following intervention. And what they actually found was that even though a vast majority of their participants actually had resolution of symptoms like we saw, a huge percentage of their athletes didn't have full return of our musculotendinous function. So again, had improvements in pain or disability, but still had deficits in terms of performance or musculotendinous function. So if we're expecting and we're throwing those patients back into sport again, the question we need to ask ourselves is that, are we actually setting our athletes up for a fall when it comes to rehab of Achilles tendinopathy? Because I would argue to a certain extent, the data tells us that we're only hitting this marker at the moment. We're not even sure, are we hitting this marker? So yes, our interventions are effective in giving pain relief or decreases in disability levels, but are our interventions actually returning our athletes to function, which ultimately will inform return to activity and return to performance ultimately. And I think we need to ask ourselves the question, because despite the relative success of interventions to date, it seems to be kind of one-size-fits-all approach to Achilles tendinopathy, or kind of a scattergun approach. And this comes across the idea of challenging the assumptions that we have. So we bludgeoned, I think, to a certain extent, is that no matter what type of athlete we have, be it a recreational hill walker to a high-level triple jumper or a 10K runner, we've given them a 12-week heavy slow intervention program, be that an Alfredson's program or a HSR program, which is increasing popularity over the last number of years, for 12 weeks, and we thought, fine, your pain improved, out you go, happy days. But again, that one-size-fits-all approach, it seems, is not addressing the functional capabilities of what the athlete needs. And particularly, we need maybe a loading continuum depending on where the athlete needs to get to. So depending on the athlete's demands or sporting demands, potentially we need to use our interventions and design our interventions to address these demands. So yes, no problem. If the person has high levels of pain at the very start, you might start off with doing some isometric exercise, which seems to be improving pain over the last number of years. And yeah, then you move on to doing some bodyweight calf exercises, and you'd roll on maybe towards doing Alfredson's heel drop program or heavy slow resistance training, which is really important to build up the maximal strength. So using an external load in terms of backpack or weights or a Smith machine, which is really important to improve the maximal strength, which is needed. But potentially, and that's over maybe a 12-week period, but after that, we need to potentially look at doing these type of activities and addressing the reactive strength or the explosive strength of that Achilles musculotendinous unit. So spending some time with the athletes, doing plyometric type work with them rather than pushing them out the door when their pain is resolved, and potentially by challenging this assumption, we can improve those outcomes for our patients when it comes around to Achilles tendon function. So that's the second assumption dealt with, and hopefully we can see that we need to challenge that assumption that improved clinical outcomes are due to restoration of musculotendinous function. So the last assumption I'm going to discuss today is the assumption relating to pain in the Achilles tendinopathy and the fact that pain is just not an issue in the tissue. I think as clinicians, we're all aware of the idea of psychosocial factors and yellow flags in other musculoskeletal areas. So we're quite comfortable with the idea of yellow flags being really, really important prognostic indicators for something like low back pain. And when I refer to yellow flags, I mean something like fear avoidance beliefs or vigilance or catastrophizing or anxiety. And what we know is that they have a huge influence on the prognostic indicators in other musculoskeletal disorders, such as low back pain or shoulder pain. And now there's emerging evidence to suggest that psychosocial factors are really important in something like sports injury as well. But I think as clinicians, we're guilty of paying a certain degree of lip service to psychosocial factors in sports rehabilitation, and particularly in my experience when it comes to Achilles tendinopathy, is that we see Achilles tendinopathy as just an issue in the tissue. And I'm going to spend, if I have a 30-minute session, I'm going to spend 25 to 30 minutes of my session addressing and fixing that Achilles tendon. That's what I need to spend my time on. And if I spend time talking to the athlete, I'm not a psychologist, so why would I need to spend time talking to the athlete? It's irrelevant. It's going to take away from my treatment time that I need to get my athlete back on the pitch. But I think that's a redundant way of thinking, and I think we definitely need to challenge this assumption. So in order to investigate this, we performed qualitative interviews of participants with Achilles tendon pain as part of my PhD. So there are one-to-one interviews, and I can hold my hands up here and say I am far from a qualitative interview. You couldn't get further. But I think out of all the studies that I'd done as part of my PhD, in terms of changing my clinical practice, this study was the one, and the findings of this study is the one that actually changed the clinical practice most for me and changed my clinical impetus as well. So what we did is we performed one-to-one interviews with people with Achilles tendinopathy. And what we wanted to see was their perceptions and their beliefs surrounding their Achilles tendon pain. So asking questions, well, how did you get your pain? Why do you think you got your Achilles tendon pain? Well, what types of treatments have you had for your Achilles tendon pain? Have they been successful? Have they not? Why have they been successful? How has the Achilles tendon pain impacted on your daily life or on your functioning or on your sporting participation? And what's your ideas around future prognosis? And I think some really, really cool themes emerge from that. So what I'm going to go through with you now is, because I think when it comes to qualitative interviews, the data speaks for themselves in terms of what the patients actually say. And what the patients actually say can have huge implications for us as practitioners. We need to spend more time listening to what they tell us in our subjective interviews. So some of the themes they came across, and one of the most important ones was rest as a management approach. So I think we're all fairly au fait now to say that, look, we know that excessive rest for a tendon is not great. But that's not what the patient hears when you're talking to him. So some of the themes and some of the quotes that came out relating to rest included, well, I was diagnosed from the start, but everyone told me, oh, you have to stop running and it'll be better in 3 weeks or maybe better in 6 weeks. No, that's not true, because they're not better. Everyone said, yeah, it's an overuse injury, just stop, take it easy, don't overdo it. And again, a similar situation when another participant who said, and then on the marathon, I actually took 5 weeks off. I actually took the month of August off. I was doing no training. I was taking rest because I actually thought that rest might help. And again, that's a common thing we hear from our participants. And that's fine if you have a fracture or something similar to that. You need relative rest, but you need to get mobilizing. And then if the tendon is highly irritable, yes, you need relative rest for a period, but we need to communicate to the patients that the best thing that they can do to decrease that irritability of their tendon and reduce their pain in the long term is actually improve the load tolerance and not rest it excessively, but actually progressively build up the load tolerance in their tendon. And rest might not be the approach to do that. And we need to address more active approaches. And again, that's just one way of we need to challenge psychosocial factors with our athletes. Some of the other themes that emerged, and again, this is quite a humorous one. I read it first, but I think it's an indictment on us as physiotherapists when you read through the quote. So one of the participants said to me, there was a therapy that was recommended to me maybe at the start of the year. It was called heel drops or painful heel drops. They're on the edge of the steps and you basically flex up and down. Was it 10 minutes a night, every night for 12 weeks? But in my head, that was crazy. And again, I don't think we ever look at it from that perspective. We are expecting someone in pain with Achilles tendon pain to do an Alfredson's heel drop program. We're asking them to do twice a day, every day for 12 weeks. And sometimes that's counterintuitive to what they may actually think. And I think we need to spend time in educating our patients, well, why I'm doing this exercise, instead of potentially at the end of a treatment handing them a form or handing them an exercise sheet and expecting to go off and do our exercises blindly without ever questioning us. We need to explain to them, well, what's the purpose of the exercise intervention I'm doing? Why do I need to do it every second day? Why do I need to do it every 3 days? Why do I need to load my tendon up to 70% of my maximal voluntary contraction? What's that going to do for my tendon? Because everyone else is telling me to rest it, that's an overuse injury. So we can't assume that the patients will do an exercise program just because we think and we understand the purpose of that exercise program. And just finally, this is probably one that many of you can familiarize with here, is that fear of future rupture or fear of future prognosis in our athletes. And this was definitely a common theme, and this came through across the board in all our participants. That fear that if I load my tendon, if I do that exercise, and if I run, I'm going to rupture that Achilles tendon. And by running on it as it is, I think get to the stage where I will rupture if I don't get it fixed. So this fear of if I load my tendon, I might rupture it. And again, that seems logical if you're the patient. If I'm in pain, why are you asking me to put more load on a structure that pathologically looks abnormal? I might actually rupture, because I've heard stories from other patients and people that I might rupture my tendon. But what we actually know is that you increase your risk by doing nothing. And by actually making your Achilles tendon and musculotendinous unit stronger, you're actually decreasing your risk of rupture. And actually, when we look at the data suggests now that in terms of spontaneous rupture, only 4% of people that have an Achilles tendon rupture actually had prior pain to actually rupturing. So the vast majority of people who do something out of the way, jump suddenly dancing at a wedding or playing a bit of five-a-side soccer, not used to it, and jump up to get a header, and they're spontaneous. Not the kind of sometimes the athletes that we see who have a gradual, insidious nature of Achilles tendinopathy. But that fear of I might rupture my tendon. So how can we expect our patients to load up to 70 to 80 to 90% of max voluntary contraction or body weight if they've got this inherent fear? So I think to a certain extent we're definitely missing a trick here and missing the boat in terms of improving adherence for our exercise interventions for people with Achilles tendinopathy if we don't simply address these factors. And it doesn't take a massive thing. I mean, I think it's a case that we just need to choose our words a bit more carefully. And instead of using negative connotations or negative statements like, and we've all done it, we're all guilty of it, of looking at an image scan or after clinical examination, that looks like a bad tendon. You have a tendon of a 60-year-old, you really shouldn't be running, you need to take some time out now, because if you don't, you're going to do more damage. And there are some of the things that we'll flippantly say to our patients without ever thinking of the impact that this may have on the patient themselves or ultimately our rehabilitation outcomes as well. So these things might actually enhance catastrophizing or enhance some of the psychosocial factors we talked about. So can we simply just use some positive reinforcement with the patient themselves? So reduce that fear and catastrophizing by potentially allaying their fears and saying, look, tendon abnormalities are actually quite common, even in people who are pain-free. And we don't need to fix your tendon, that we can actually improve your pain gradually by loading progressively, and this will actually reduce the sensitivity of your tendon and get you back running bit by bit. But we need to start off slowly, we won't push you too far, and we'll get you there step by step. And they're just simple tips that we can make to the patient, or about laying their fears about rupture, giving them that statistic I just talked about you there, and avoiding treatments that emphasize on fixing tendon morphology or tendon structure, and the emphasis that pain doesn't equal damage. So yeah, their tendon might be sensitive, but that doesn't necessarily mean they're doing huge amount of damage to their tendon. That just tells me that their tendon is sensitive, and I need to decrease that sensitivity by gradually loading it. And again, they need to promote the belief that progressive exercise program is needed to increase that load tolerance of the tendon. So hopefully we can see that we're missing a trick when it comes to psychosocial factors, and potentially we need to improve these psychosocial factors as well. So you'll be happy to hear that's our third assumption dealt with. That assumption that pain and tendinopathy is just an issue in the tissue. And I think the key points from today, if we took away anything else, is that I'm not dissing saying what we've done to date has been wrong on Achilles tendinopathy. We've made fantastic improvements with Achilles tendinopathy in terms of conservative exercise interventions, and exercise definitely works when it comes to reducing pain and disability in our athletes. But I think we need to challenge some of the assumptions that we had around the mechanism of action of our interventions, to potentially improve some of those recurrence rates and some of those persistence of symptoms that can be frustrating for us as clinicians, but very frustrating for our athletes when they do have a tendon disorder. So exercise is helpful, but not a panacea. Interventions should focus potentially less on fixing structural morphology and focus more on altering the mechanical properties of the tendon, like we talked about that stiffness and that strain, and those mechanical properties, how the tendon behaves under load. So load it heavy and don't worry about the contraction type that you're using. When it comes to rehab, it's not a one-size-fits-all intervention approach. And again, what's good for the goose may not be good for the gander, as we like to say in Ireland. So this one-size-fits-all of, I give my patient a 12-week loading intervention and happy days, that's all I need to do. I'm king from now on. But it depends on the participant's loading demand or the athlete's loading demands. Have I ensured that I've restored sufficient amounts of musculotendinous function to get them to the point they need for exercise performance? And I think lastly, and what we just covered there, is that not addressing psychosocial factors may negatively affect athletes' rehabilitation outcomes. And I think we need to change this prevailing attitude that, oh, we're not psychologists. No one's asking you to be a psychologist, but spend some time knowing your athletes. Talk to them briefly, challenge any beliefs that they have, but ultimately challenge some assumptions that they have, but internally challenge some of the assumptions that you have about treatment and the mechanism of action of your interventions, because ultimately what we want to do is improve the rehab outcomes for athletes. And I'm just going to leave you with a famous quote by the philosopher Master Yoda, who said, "You must unlearn what you've learned." And I think that's a certain degree too when it comes to Achilles tendinopathy. We've made huge improvements, and exercise definitely helps, but we need to challenge some of the assumptions that we previously had. I'd just like to thank a couple of people. I'd like to thank the research department for giving me the opportunity to present this Tuesday lecture. I'd like to thank the clinical therapies department at the University of Limerick in Ireland, providing me with the opportunity to undertake my PhD, and particularly my supervisors, Kieran O'Sullivan, who did a runner, classic Kieran O'Sullivan, he mustn't have liked what I said, Karen McCreesh and Helen Purtle for their supervision over the last couple of years. And hopefully you all enjoyed the lecture and understood my terrible Irish accent, and I'm happy to answer any questions.